Chapter 10, Pediatric and Geriatric Procedures. Chapter Objectives. Upon completion of Chapter 10, the learner should be able to do the following. Describe fears or concerns that children of various ages might have regarding the blood collection process. List suggestions for patients and healthcare workers during a venipuncture or skin puncture. Identify puncture sites for a heel stick on an infant and describe the procedure. Explain the special precautions and types of equipment needed to collect capillary blood gases. Describe the venipuncture sites for infants and young children. Discuss the types of equipment and supplies that must be used during skin puncture and venipuncture for infants and children. Describe the procedure for specimen collection for neonatal screening. Define 5 physical and/or emotional changes that are associated with the aging process. Describe how a healthcare worker should react to physical and emotional changes associated with the elderly. Collecting blood from pediatric, baby or child, and geriatric, elderly patient requires much clinical knowledge about and training for the proper techniques. Both of these age groups require extra care in blood collection. Pediatric patients. Children are not just little adults, and they should not be treated as such. The healthcare worker needs to be familiar with special types of equipment that are available. Observe the various techniques as they are performed by a healthcare worker experienced in pediatric phlebotomy and practice the techniques to develop the necessary skills. The healthcare worker also must learn how to talk with children of various ages to calm them for a blood collection. Performing venipuncture or skin puncture on young patients is challenging because children have smaller bodies and are less prepared to cope with pain and anxiety. When learning the techniques, remember to ask for help if needed and to allow adequate time to develop the necessary skills. Preparing child and parent. The timing of the preparation depends on the child's age. Generally, the younger the child, the closer the explanation should be to the time of the procedure. Preparing the child and the parent for the blood collection procedure involves the following steps. Number 1, a calm, confident approach is the first step to obtaining the cooperation of the child and parent. Introduce yourself. Be warm and friendly. Establish eye contact with both the child and the parent and show that you are concerned about the child's health and comfort. When you interact with a pediatric patient and his or her parent, provide a sense of trust and confidence. Correctly identify the patient. Number 2, correctly identify the patient by using at least 2 patient identifiers. The patient should have an identification bracelet with his or her name and hospital number or birth date. Verify this information. A hospitalized infant usually has the identification bracelet on his or her ankle. Newborns who have not yet been named are usually identified by their last names, such as Baby Boy Smith and Baby Girl Jones. An identification number. If the mother is still in the hospital after the delivery, the baby may wear an identification band that is cross-referenced to the mother. Keeping identification straight is always crucial, but especially so when specimens from twin babies must be collected and labeled. Number 3, find out about the child's past experience with blood collections. Ask whether the child has ever had blood collected. The child and the parent can then tell you about their experiences with past procedures and provide you with valuable information about the approaches that worked effectively for them and those that were not as successful. Number 4, develop a plan. Ask the parent how cooperative his or her child will be. Parents are excellent predictors of their child's behavior and possibility for distress. Usually the younger child with poor venous access will have more distress. A successful plan involves not only the parent's suggestions about what will be most helpful, but also the healthcare worker's knowledge about pediatric phlebotomy techniques, if possible. Allow the child to have some control by offering a choice of which arm or finger he or she prefers for blood collection. Number 5, place yourself at the child's eye level to explain and demonstrate the procedure. When explaining what you will be doing, use words appropriate for the child's age. Use of a doll, puppet, or stuffed animal in the demonstration can help you relate to the child in a non-threatening manner. If the child has a favorite doll, blanket, or toy, he or she should be encouraged to hug it for comfort and support. Number 6, establish guidelines. Tell the child and the parent that the procedure will most likely be successful on the first attempt. If not, it will be attempted only once more by another healthcare worker. Number 7, be honest. When a child asks whether the puncture will hurt, tell the child that if the procedure hurts too much, it can be momentarily stopped, but that the more quickly the procedure is performed, the less painful it will be. Instruct the child to say when he or she feels the pain or hurt. Tell the child that saying ouch or making faces is acceptable, but that he or she must make an effort to keep the arm absolutely still. Reassure the child that the blood will be collected as quickly as possible so that the pain will be brief. Number 8, encourage parent involvement. Explain how the parent can assist by holding, distracting, and soothing their child during the procedure. Some parents, however, may be reluctant to participate because they do not want to be a part of a procedure that will cause their children pain. If the parent does not wish to assist but is willing to be in the room, ask him or her to maintain eye contact with the child to reduce stress. If after discussing his or her role, the parent is still reluctant to be in the room, respect his or her wishes. If the parent does not wish to participate, you may ask another healthcare worker to assist. Psychological responses to needles and pain. Children especially fear needles, and an emotionally upset child has difficulty separating fear from actual pain. Children 1 to 2 years old may react extremely to painless procedures such as taking a temperature. Children of 3 to 5 years old perceive pain as a punishment for bad behavior. They may react aggressively. Children 6 to 12-year-old are more likely to relate pain to past experiences. Many children perceive that a shot or needle hurts more than anything else and has ever happened to them. Children 13 to 17 years old are more independent and may be embarrassed to show fear. They usually need privacy and may act hostile to mass fear. With proper preparation, the child and the parent can develop coping skills to help lessen the fears and thereby diminish the hurt. Clinical alert. It is not unusual for a sick, injured child to act younger than he or she really is. If a child who is 6 behaves like a 3-year-old, use strategies appropriate for a 3-year-old. The following parental behaviors and examples will have a positive effect on relieving the child's distress. Behaviors. Distraction. Examples. Look at mommy. Tell us all about your doll. Behavior. Emotional support. Example. Hugging, stroking the hair, patting, and talking in a soothing voice. Behavior. Explanation. Examples. We need to take a tiny bit of blood from your finger. You will feel a little prick. Mommy will help hold your arm so that we can finish quickly. Behaviors. Positive reinforcement. Examples. You did a great job in holding your arm still. Distraction techniques. Children older than 3 years old respond well to distraction techniques to help them cope and lessen distress. Distraction helps the child refocus on a more pleasant experience. A parent or another healthcare worker can provide the distraction. Some examples of distractions are blowing bubbles, pinwheels, counting, reading a book or looking at a video, listening to music, singing, or talking in a gentle voice about something enjoyable. School-aged children may respond to strategies such as picturing themselves in a pleasant setting or participating in the procedure. Room location. For psychological reasons, the best room location for a painful procedure is a treatment room, away from the child's bed or playroom. For a hospitalized child, the bed should be a safe, secure place to rest and sleep, not a place associated with pain. The child shares a room with another child. Performing the procedure at the bedside can be upsetting to the roommate as well. If the child cannot be moved to a treatment room, maintain privacy by drawing a curtain between the beds and speaking in a calm, gentle manner. Equipment preparation for a friendlier environment. Just the sight of needles, syringes, and a person in a white laboratory coat can be frightening to a child. When working with children, wear bright, colorfully printed uniforms or smocks to create a child-friendly environment. Prepare the phlebotomy equipment and supplies before entering the child's room, so that the child does not become even more anxious by watching the preparation. Use shorter needles if possible, and keep threatening-looking supplies such as needles covered and out of sight until you are ready to begin the procedure. If the hospital policy requires goggles or face shields for blood exposure precautions, put the equipment on after greeting the child. Praise the child throughout the procedure. At the completion, reward the child with a colorful bandage, a sticker, and an age-appropriate toy, or with parental permission, a lollipop. If a parent is not present to assist in relieving the anxiety, offer pacifier to an infant or gently stroke or talk softly to soothe a small child. Positions for restraining a child. Holding a child may be required to ensure that the child does not move his or her limb, such as arm, finger, or foot, during blood collection. Restraining techniques should be compassionate, safe, and performed quickly. A supportive parent who has been properly instructed can assist with restraining while providing comfort to the child. Two preferred comfort methods of restraining a child to immobilize the arm are the vertical position and the horizontal or supine position. In both cases, the patient's face is close to the child's, thereby providing a comforting and secure feeling. The vertical technique, which works well for toddlers, requires the child to be held on the parent's lap as the parent hugs and holds the child's body and the arm not being used. The healthcare worker can firmly hold the other arm to perform the procedure. In the horizontal position, a baby can easily be held by a parent. However, more restraint may be needed for the older child. If the child lies supine with the healthcare worker on one side of the bed and the parent on the other side of the bed, the parent can gently but firmly lean over the child, restraining the child's arm not being used while holding the opposite extended arm securely for the healthcare worker. Neonates and infants younger than 3 months usually do not require restraint and can be managed by the healthcare worker alone. Swaddling helps to control and comfort the upset newborn. Combative patients. At times, a child will become uncooperative even after the proper steps have been followed to gain cooperation. Children may become combative, kicking and thrashing if force is used. Because sharps are involved in blood collections, the healthcare worker must be certain that the procedure can be performed safely. Using force to the point of potential physical injury is unethical and unprofessional. Therefore, if the risk of injury to the child or the healthcare worker is likely, discontinue the blood collection attempt and notify the nurse and/or physician. Decreasing the needle stick pain. A topical anesthetic pain reliever, such as EMLA, can be rubbed on the skin when needle stick is going to be used for venipuncture to a child. This local anesthetic is ideal for use before venipuncture or starting IV therapy because it does not require a needle. It is applied to the skin as a patch or a cream that is then covered with a transparent adhesive dressing. Optimal anesthesia occurs after 45 to 60 minutes and may last as long as 2 to 3 hours. Drawbacks to the use of EMLA are cost, the need to apply 60 minutes before the procedure, and having to know in advance the location of the vein to be used. 2 separate locations may be anesthetized if the child has difficult veins from which to obtain blood. Do not use EMLA if the child is allergic to local anesthetics. Oral sucrose. Sucrose is effective in reducing pain and crying time during a procedure for an infant up to 6 months old. A 25% solution of sucrose can be prepared by mixing 4 teaspoons of water with 1 teaspoon of sugar. The sucrose can be carefully administered by oral syringe, dropper, nipper, or on a pacifier. A sucrose nipple or pacifier is given 2 minutes before heel sticks, and its action lasts for about 5 minutes. Some studies show that infants given pacifiers or sucrose have also been shown to be more alert after the procedure, to be less fussy, and to cry for shorter duration. Precautions to protect the child. Premature infants, newborns, and children who are chronically ill or have extensive burns are more likely to be susceptible to infection. To protect these children from potentially harmful microorganisms, some hospitals may require protective precautions. In this instance, PPE gowns, gloves, and masks will be worn as indicated before entering the room. After the procedure, remove the PPE according to the policy and dispose of it in the appropriately marked container. Wash your hands or sanitize them according to the policy. Alcohol-based waterless rubs, foams, or rinses are as effective as hand washing if the hands are not soiled. Put on a clean gown and gloves before attending the next infant or child. Clinical alert. Puncturing deep veins in children may cause cardiac arrest, hemorrhage, venous thrombosis, damage to surrounding tissues, and infection. Pediatric phlebotomy procedures. Two methods are used to obtain blood from infants and children: microcapillary skin puncture and venipuncture. The previous described steps for preparing the child and the parent should be taken before either procedure is performed. Microcapillary skin puncture. Skin punctures are useful for pediatric phlebotomy when only small amounts of blood are needed and can be adequately tested. It is particularly important to collect only the smallest amounts of blood necessary from neonates, infants, and children so that the effects of reductions in blood volume are minimal. Over-collecting during phlebotomy may require packed blood cell transfusions in an infant. Small infants can easily become anemic if too much blood is taken. To avoid overcollection of blood by phlebotomy, the amount of blood collection from the infant and child must be recorded and maintained. Each hospital treating pediatric patients should determine the amounts of blood to be collected from patients on the basis of weight and the maximum cumulative amount of blood to be collected during a specified time period. When performing skin punctures, collect the hematological specimens first to minimize platelet clumping. Then collect for chemical and blood bank specimens. Each laboratory has approved procedures for phlebotomy, including the volume of blood that is required for each test. Always follow these procedures. Always record the amount of blood collection. Skin puncture sites. The heel is the most desirable site for skin puncture on an infant or neonate. Use the most medial or most medial or most lateral section of the plantar or bottom surface of the heel. Do not use the central area of the infant's heel for blood collection. Procedure 10-1, heel stick procedure. Rationale: to perform a blood collection from the infant's heel. Equipment: the following equipment is necessary for pediatric skin puncture: sterile, automatic, disposable pediatric skin puncture, safety devices in different manufacturers, incision depths, 0.65 to 0.85 millimeter for premature infant neonates, 1 millimeter for large infants. Please see Chapter 6, Blood Collection Equipment, for photo examples. 70% isopropyl alcohol swabs, sterile 2x2 gauze sponges, plastic capillary collection tubes and sealer or caps, micro collection containers, glass slides for smears, puncture-resistant sharps container, disposable gloves, non-latex if the child is allergic, compress to warm heel if necessary, a marking pen, laboratory request slips or labels. Preparation: prepare and assemble supplies. Remember, do not place a specimen collection tray on the infant's bed or in the bassinet. Introduce yourself to the parents, explain the procedure, and use appropriate comfort techniques. Identify the infant properly. Identify the infant by name, address, and identification number and/or birth date, and compare with laboratory test request form. If the infant is not wearing an identification bracelet, the name of the person who performs this identification procedure must be documented in the medical records and/or charts. Procedure: wash or sanitize your hands with an alcohol hand rub, then put on gloves if required, don a gown, and a mask. Inspect the selected area and assess it for proper warmth. If it is cool or a blood glass specimen is to be collected, pre-warm the foot with a warm wet towel or a chemical heel warming pack according to policy. Wipe the heel dry after removing the warm towel. Position the baby in a supine or lying position with the knee at the open end of the bassinet. This position allows the foot to hang lower than the torso, improving blood flow. When the baby is in an acceptable position for this procedure, clean the intended incision site or allow the heel to continue to come into contact with any. Do not touch the incision site or allow the heel to come in contact with any non-sterile items or surfaces. Heel warming. Rationale: the amount of blood that can be obtained from a single heel stick is limited. Therefore, to obtain an adequate sample, pre-warming the heel may be indicated. Pre-warming the heel increases blood flow and arterializes the specimen. This step is essential for collecting specimens for capillary blood gas analysis. Prepare and assemble supplies: warm wet towel and a plastic bag or a chemical heel warming pack. Warm the site with a commercially available warming pack or wrap a warm wet towel at a temperature no more than 42 degrees Celsius around the infant's foot. If the temperature of the towel exceeds 42 degrees Celsius, it may burn the infant. Encase the towel in a plastic bag to help retain heat and keep the patient's bed dry. Use caution if the towel is heated in a microwave oven because heating is uneven and the towel may have hot spots. Pre-warm the site for 3 to 5 minutes. Depending on the institution's policy, call in advance to pre-warm the infant's heel. Remove the appropriate tender-foot puncture device from the blister pack, taking care not to rest the blade slot in on any non-sterile surface. Remove the safety clip. Note, the safety clip may be replaced if the test is momentarily delayed. However, prolonged exposure of any tenderfoot device to uncontrolled environmental conditions before use may affect the sterility. Once the safety clip is removed, do not push the trigger or touch the blade slot. Hold the infant's foot firmly but gently to prevent sudden movement. Holding the foot too tightly may cause bruising and restrict blood flow. Also, it can lead to erroneous laboratory test results. Raise the foot above the baby's heart level and carefully select a safe incision site. Avoid any edematous area or site within 2 millimeters of a prior wound. Place the blade slot surface of the device flush against the heel so that its center point is vertically aligned and the desired incision site. Clinical alert. Avoid excess milking or squeezing, which causes hemolysis and dilutes the blood with interstitial and intracellular fluid. Ensure that both ends of the device have made light contact with the skin. Depress the trigger. After triggering, immediately remove the device from the infant's heel and dispose of it in a biohazard sharps container. Using only a dry sterile gauze pad, gently wipe away the first drop of blood that appears at the incision site. Taking care not to make direct wound contact with the collection container or capillary tube filled to the desired specimen volume. Take care not to scoop blood into the microtube, as this technique can lead to hemolysis. After blood collection, gently press a dry sterile gauze pad to the incision site until the bleeding has ceased. This step will help prevent a hematoma forming. Label the specimen container and verify identification. Record the time of collection. After the procedure, care of the heel. Elevate the heel slightly above the body and ensure that bleeding is stopped. Check the infant's heel puncture site for late bleeding or inflammation. Clinical alert. Use of an adhesive bandage over skin puncture site is not recommended for children under 2 years old. Infants have delicate skin that may be irritated by the adhesive strip, and an older infant might remove it and put it in his or her mouth. Bandages can also be swallowed by older children. Cleanup. Dispose of the used skin puncture device in a sharps container with a biohazard label. Check the infant's bed for any equipment or trash left behind. Discard blood-soaked gauze, sponges, grossly contaminated items, and gowns or gloves used in isolation rooms in biohazard waste containers. Dispose of gowns and gloves that are not from isolation rooms in regular trash. Wash or sanitize your hands after removing the gloves. Use improper pediatric size skin puncture device. Make an incision that is less than 2.0 millimeters deep. Major blood vessels lie 0.3 to 1.6 millimeters beneath the skin at the dermal subcutaneous junction in newborns. If an incision goes deeper, the calcaneus or heel bone may be hit, which may lead to osteomyelitis and or osteochondritis. For children older than 1 year, the palmar surface of the distal phalanx fingertip section or of the third, middle, or fourth ring finger is most frequently used because the thumb has a pulse and index finger may be more sensitive. The fifth finger is not used because the skin is too thin. The plantar surface of the great toe is not recommended for skin puncture. Clinical alert. Do not obtain blood by skin puncture from the toes or the central area of an infant's heel because this may result in injury to nerves, tendons, and cartilage. Do not use fingers of infants less than 1 year of age or previously punctured sites. If an infant has compromised circulation to the extremity, as in shock, or has edema, bruises, rashes, or infection at the heel, use another site, such as a venipuncture procedure. Capillary blood gases. Arterial blood is the specimen of choice for blood gas testing. However, capillary skin puncture blood can be collected from infants and small children for blood gas analysis because this procedure is safer than an arterial puncture. Skin puncture blood blood is less desirable as a specimen because it contains blood from capillaries, venules, arterioles, and fluids from surrounding tissue. In addition, common collection methods for capillary blood gas specimens use an open collection system in which the specimen is temporarily exposed to room air, which allows for a brief exchange of gases, both O and CO2, before the specimens are sealed from the air. The air exposure must be minimized to avoid falsely elevated blood oxygen levels. 10.2. Collection for capillary blood gas testing. Rationale. To perform a blood collection for capillary blood gas analysis. Blood for capillary blood gas analysis is often collected from small children and babies for whom arterial punctures can be too dangerous. Samples are collected from the same areas of the body as other capillary samples, such as the lateral posterior area of the heel or the ball of the finger. Equipment: sterile automatic disposable pediatric skin puncture safety devices in different manufacturers' incision depths. Heparinized safety plastic capillary tubes. 70% isopropyl alcohol swabs. Sterile 2x2 gauze sponges. Plastic capillary collection tubes and sealer. Micro collection containers. Glass slide for smears. Puncture resistant sharps container. Disposable gloves, non-latex if the child is allergic. Warming packs or compress to warm heel if necessary. A marking pen. Laboratory requisitions or labels, ice water, minute metal filing, a magnet. Preparation. Prepare the assembled supplies. Introduce yourself to the parents, explain the procedure, and use appropriate comfort techniques. Identify the infant properly. Warm the site according to the institution's procedures. Wash or sanitize your hands with the alcohol hand rinse, then put on gloves. If required, put on a gown and a mask. Use a heparinized safety plastic capillary tube for collection. Perform the capillary skin puncture as previously mentioned and wipe away the first drop. Fill the capillary tube with blood end to end. Obtain the stated fill volume of the tube. Cap one end of the capillary tube. Insert a small metal filing referred to as a flea or mixing wires into the filled capillary tube. Place the magnet over the tube and cap on the other end of the tube. The specimen must be collected with no air bubbles, which can cause inaccuracies in the values obtained from the specimen. Use the magnet to draw the metal filing flea back and forth across the length of the tube to mix the specimen completely. Label the tube and notify laboratory personnel of an urgent blood gas test to be performed. Press the skin puncture site with a clean gauze sponge until bleeding stops. After the procedure, care of the heel. Elevate the heel slightly above the body and ensure the bleeding has stopped. Check the infant's heel puncture site for late bleeding or inflammation. Cleanup. Dispose of the unused skin puncture device in a sharps container with biohazard label. Check the infant's bed for any equipment or trash left behind. Discard blood-soaked gauze, sponges, grossly contaminated items, and gowns or gloves used in isolation rooms and biohazardous waste containers. Dispose of gowns and gloves that are not from isolation rooms in regular trash. Wash or sanitize your hands after removing gloves. Deliver the sample immediately to the laboratory. Delays of more than 15 minutes at room temperature will affect results. Finger sticks on children. A finger stick to obtain blood for routine laboratory analysis is usually preferred for children under 1 year. Also, a finger stick may be necessary if a child has damaged veins from repeated venipuncture or if the veins are covered with bandages or casts. Do not perform a finger stick if the finger is swollen, edematous, cyanotic, or infected. Use a pediatric safety skin puncture device designed for the age and size of the child. An automatic skin puncture device controls the puncture depth, which should not exceed 2 millimeters in small children. Automatic puncture devices are available in sizes that incise the depths of 0.85 millimeters for preemies, 1.25 millimeters for infants, and 1.75 millimeters for toddlers. For a detailed description of collecting capillary blood specimens from the finger, refer to Chapter 9, Capillary Blood Specimens. Neonatal screening. In the United States, newborn babies or neonates are routinely screened for a variety of metabolic and genetic defects by analysis of blood collection on a special filter paper. Neonatal screening is important for the early detection, diagnosis, and treatment of certain genetic, metabolic, and infectious diseases. Many of these diseases can result in severe abnormalities, including mental retardation if they are not discovered and treated early. Blood spot testing for screening is performed before the newborn is 72 hours old. If the blood specimen is collected before the newborn is 24 hours old, because of early discharge from the hospital, a second specimen for screening must be collected before 2 weeks of age. Collection of capillary blood for neonatal screening. Rationale: to perform a capillary blood collection for newborn screening specimens. The heel of the neonate is the most frequently used site for collection of blood for screening. The following equipment is necessary for newborn screening blood collection: sterile, automatic, disposable pediatric skin puncture safety devices in different manufacturer incision depths. Please see Chapter 6. 70% isopropyl alcohol swabs, sterile 2x2 gauze, newborn screening cards. Appropriate collection cards are kept in the hospital laboratory or in the nursery. Do not use cards that are beyond the expiration date on the filter paper. Puncture-resistant sharps container, disposable gloves, non-latex if the child is allergic, warming packs or compresses to warm the heel if necessary, mark and pen, laboratory requisition labels. Preparation: prepare and assemble supplies. Introduce yourself to the parents if they are present. Explain the procedure and use appropriate comfort techniques. Identify the infant properly. If the infant is not wearing an identification bracelet, identify the infant by name, address, and identification number and/or birth date, and compare this information with the laboratory test request form. Fill out the information on the newborn screening card shown in Figure 1021. Warm the site according to the institution's procedures. Procedure: wash or sanitize your hands with an alcohol hand rinse, then put gloves on. If required, don a gown and a mask. To prevent contamination, do not touch with hands or gloves any part of the filter paper circles before, during, or after collection. Do not allow the filter paper to come in contact with the substances such as alcohol, formula, water, powder, antiseptic solutions, or lotion. Circles are printed on the filter paper portion of the card as shown in Figure 1022. Perform the capillary skin puncture as previously mentioned and wipe away the first drop of blood with a sterile gauze sponge. Allow another large blood drop to form. As shown in Figure 1022, lightly touch the printed side of the filter paper with the blood drop and fill each printed circle. Allow the blood to soak through and completely fill the circle with a single application of a large drop of blood. If the circle does not fill entirely, wipe the heel and express another larger drop to a different circle. Do not add a second drop of blood to a previously used circle. The filter paper must not touch the skin puncture site. Only use one side of the filter paper. Dry blood spots on a clean, dry, flat, non-absorbent surface for a minimum of 4 hours. Direct application of blood from the heel to the card is the technique of choice. Most newborn screening laboratories will not accept blood spots collected by a capillary tube because of the testing will not be accurate. Press the skin puncture site with a clean gauze sponge until the bleeding stops. After the procedure, care of heel. Elevate the heel slightly above the body and ensure that bleeding has stopped. Check the infant's heel puncture site for late bleeding or inflammation. Cleanup. Dispose of the used skin puncture device in a sharps container with a biohazard label. Check the infant's bed for any equipment or trash left behind. Discard blood-soaked gauze sponges, grossly contaminated items, and gowns or gloves used in isolation rooms into biohazardous waste containers. Dispose of gowns and gloves that are not from isolation rooms in a regular trash. Wash or sanitize your hands after removing the gloves. Correctly complete all information on the screening card so that follow-up can be done if the results are abnormal. Place the screening card in an appropriate envelope and send it to the laboratory within 24 hours. Interferences in newborn screening collections. It is important to be cautious and careful in blood collection and transfer to the filter paper for the newborn screening. Many interferences result from poor blood collection techniques. The most common include the following: blood specimen not properly dried before mailing, filter paper circles not completely filled, not saturated with blood, or not all circles filled, contamination of filter paper circles before or after blood collection by substances such as hand lotion, powder, alcohol, antiseptic hand solution, or touching areas with gloved or ungloved hands. Blood applied to both sides of filter paper. Excess blood applied usually occurs with the capillary tube. Heel stick squeeze or milk result in tissue diluted specimens. Alcohol not wiped off the heel stick site before puncture is made. Venipuncture on children. Venipuncture on children is used when large quantities of blood are needed for sampling. The veins of the antecubital fossa or forearm are the most accessible and are chosen for most toddlers and children. If a venipuncture is done on a child younger than age 2, the site should be limited to a superficial vein. Some studies have indicated that venipuncture, when performed by a skilled healthcare worker, appears to be the method of choice for blood sampling for neonates, as it is less painful and can provide adequate blood testing. Other sites used for venipuncture are the medial wrist, the dorsum of the foot, the scalp, and the medial ankle. Always check the policy at your facility before performing venipuncture on foot and ankle veins. If the neonate or child is receiving fluid or medication intravenously, the distal veins should be avoided for phlebotomy and preserved for IV therapy. Venipuncture is indicated for blood sampling for routine laboratory tests, erythrocyte sedimentation rate, blood cultures, cross-matching, coagulation studies, and drug and ammonia levels. Do not use veins in extremity or area that edema or infection, or if an IV line is present. Avoid deep veins in a child with hemophilia or other bleeding disorders. Precautions. Remove the tourniquet before withdrawing the needle. Apply pressure to the gauze sponge for 3 minutes to prevent hematoma. Do not use alcohol pads to apply pressure, as they will cause stinging and prevent hemostasis. Equipment of choice for venipuncture on a small child is a winged safety butterfly needle. Equipment for venipuncture. The equipment necessary for a pediatric venipuncture includes the following: winged safety infusion butterfly needle, 21 gauge by 1 inch or 23 gauge by 3/4 inch. Syringes slightly larger than the volume of blood needed. Paper tape. 70% isopropyl alcohol swab in sterile package. 2x2 gauze. Appropriate specimen containers. Pediatric size tourniquet. Non-latex if the child is allergic. Sterile disposable gloves. Non-latex if the child is allergic. For blood culture, bottles both aerobic and anaerobic. For smaller children, use a special pediatric bottle. The required volumes for children ages 2 to 12, 2 to 4 milliliters. For infants under age 2, 1 milliliter. Iodine swabs. Chlorhexidine gluconate swabs, used for infants 2 months and older rather than iodine. Bandage strip, for use only with older children. Marking pens and biohazard waste container. Procedure. The procedure for performing venipuncture on children is similar to that for adults. See performing a venipuncture in Chapter 8. The difference includes the necessary preparation of the child and the parent, assistance in restraining a child, and the use of special pediatric needles or safety winged infusion sets. After the child is securely positioned, place the tourniquet proximal to the selected vein to distend it. If necessary, the limb may be lowered. Rub gently or warm to promote dilation of the veins. Disinfect the site thoroughly. Allow the alcohol to dry completely. Then hold the two wings of the infusion set together in the dominant hand as the other hand pulls taut the skin below the puncture site. After inserting the needle and when blood appears in the tubing, release the wings of the infusion set. The skin will hold the needle in place, or tape can be used to secure it. Gently aspirate the syringe until the required amount of blood is collected. Release the tourniquet and apply pressure over the puncture site with a gauze pad as the infusion set is quickly removed. Ask the patient or the nurse to hold pressure on the site until the bleeding stops. A colorful bandage strip may be used on an older child. Remove the syringe from the safety butterfly set after the needle safety guard has been engaged. Then attach the syringe to a safety syringe shield transfer device for safe transfer of blood to the collection tubes. Geriatric patients. The elderly or geriatric population is growing at an amazing rate. With 75 million United States citizens, those born between 1946 and 1964, and known as the baby boomer generation, swelling the ranks. With the life expectancy in the United States improving dramatically due to medical advances, many of these baby boomers will live into their 90s and maybe up to 100. Thus, healthcare workers will be providing healthcare services for patients that have various types of chronic diseases and disorders, such as diabetes, cardiovascular disease, chronic obstructive pulmonary disease, arthritis, etc. Physical conditions such as arthritis, Parkinson's disease, a disease causing tremors, Alzheimer's disease, a disease causing loss of intellectual abilities, and mood disorders such as depression and combativeness, and other debilitating diseases in elderly persons will continue to increase point-of-care testing by skin puncture because of the difficulty of obtaining blood by a venipuncture. In addition, this patient population will increasingly need point-of-care testing and other healthcare services in their homes, nursing homes, rehabilitation centers, and other long-term care facilities where the length of stay is over 30 days. The process of aging presents physical and emotional problems that can be challenging for healthcare workers. Whatever the situation, treat elderly individuals with the utmost respect and dignity. Physical problems that are common in older individuals include the following. Hearing loss may cause embarrassment and frustration. Repeating instructions or facing the patient to speak in the good ear may be necessary for the patient to truly understand a procedure. Impaired verbal communication due to stroke, Parkinson's disease, Alzheimer's disease, or other chronic conditions. Failing eyesight is common, so take care to guide the elderly individual to the appropriate seat for blood collection or to the bathroom for urine collections. Loss of taste, smell, and feeling can accompany the aging process. Elderly people may lack an appetite, which may lead to malnourishment and dehydration. They may tend to drop things or not to be able to make a fist because of muscle weakness. Make a note of these clues, particularly if the patient is homebound without a caregiver. Memory loss can affect the patient's ability to take medications or to remember the last time he or she ate. These factors may interfere with interpretation of laboratory results. Skin tissue becomes thinner, thereby making venipuncture more difficult. Hold the skin extra taut so that the vein does not roll. Also, do not slap the arm when trying to locate the vein. This causes bruising. Use of heated compresses can be helpful. Muscles become smaller, so the angle of penetration of a venipuncture needle may need to be more shallow. Increased susceptibility to accidental hypothermia, a subnormal drop in body temperature, can make the elderly patient feel cold. Thus, specimen collection may require warming of the site. Increased sensitivity and allergies, ask patient whether they have any allergies. Anxiety related to becoming older and less capable of performing everyday living activities. Emotional problems that are associated with aging include possible loss of career, spouse, close friends, or relatives, and can be reflected by depression or anger at life in general. Remember to address elderly persons with dignity and respect by using Mr., Mrs., Miss, and so on. Also respect the patient's privacy. Consideration in home care blood collections. Because many elderly people have limited mobility and are unable to travel to a healthcare clinic, it is becoming increasingly common for healthcare workers to travel to homes to collect blood for diagnostic and treatment purposes. If specimens are to be collected in homes, all procedures are similar to those already covered, except the healthcare workers should take extra supplies and equipment, including biohazard containers for disposables and a temperature-regulated specimen transport container into the home. Positively identify the patient if possible. If not possible, develop the following procedures of the health care organization. Place the patient in a comfortable, preferably reclining position in case of fainting. Carry hand disinfectant and other supplies and equipment and use the disinfectant on your hands before collecting blood. Locate a bathroom for access to hand washing. Wait for the puncture site to stop bleeding because many elderly patients take medications that prolong bleeding. Carefully inspect the area after the procedure to ensure that all trash and used supplies have been properly discarded. Carefully label the specimens and place them in leak-proof containers with biohazard sign on the container. Check the appropriate temperatures for transport. Locate a bathroom for access to hand washing. When working in the high crime areas, take security precautions. Travel with a mobile phone and carry maps or GPS to avoid getting lost on the way to or from the patient's home. Carefully document delays and return the specimens to the laboratory. Chapter 8, venipuncture procedures, and Chapter 9, capillary blood specimens, also provide procedures that apply to elderly patients. In these blood collections, factors to consider for older patients are the types of blood collection equipment to use. For example, using a safety butterfly needle is usually more appropriate for elderly patients' fragile veins. Consider the physiological situation of the geriatric patient in the decision to obtain a quality blood specimen for laboratory tests. This concludes Chapter 10.